Okay, the survivors are here. The one who could come back without having coffee with all the sweet delights that were there. And we opened the last session. We have a wonderful session this morning. And we have the last session with two speakers. I will present the first one, Galia Oron from Israel. She is the head of the IVF in northern part of Israel in Carmel Hospital. She trained in Tel Aviv and in McGill. And now she's with us, and she's going to tell us about fertility preservation for poor responders. Can we preserve anything? Please, Galia.
So thank you for the kind introduction. Wow, it's really strong. I'd like, can you lower it a bit? It's really, really hard for me to talk. So I'd like to present fertility preservation in poor responders. Does 5 plus 5 really equal 5? Really equal 10. I would like to thank Fering Otilia, the organizing committee, for inviting me to give this talk. I have no disclosures that are relevant for this talk. So in 2013, the ASRM no longer classifies social fertility preservation as an experimental procedure, therefore causing a surge in the demand for fertility preservation for women who wish to delay parenthood. Over the years, consensus expert panel groups recommend to change the potentially stigmatizing term social egg freezing into elective non-medical egg freezing, planned oocyte cryopreservation, and age, oocyte banking, anticipated gamete exhaustion. Women freeze their eggs for all sorts of indications: psychological, for fear of age-related fertility decline; professional, completing education and career advancement; financial, waiting for the right time to be financially independent and start a family; and for personal reasons, mainly the lack of a male partner. Initially, the press was very positive. We all remember Bridget Adams appearing on the Bloomberg Businessweek cover, calling women to freeze their egg and free their career. When Adams was interviewed for this magazine, she said that she felt that freezing her eggs gave her incredible calmness to balance life and work and fertility and future family planning. But what happened was that 4 years later, when Bridget Adams was 44, she thawed the 11 eggs. Only 9 survived the thawing process. 6 were fertilized. 1 embryo was transferred into the uterus, resulting in a chemical pregnancy, thereby ending her journey towards parenthood. Over the years, negative press started appearing, highlighting the regrets, and there was a call for us, the physicians, the scientific community, to start publishing success rates. And maybe it's time to focus more of our research on the outcome of fertility preservation so we could provide personalized, evidence-based advice and improve preservation strategies instead of just promoting a freeze now, think later approach. The scientific data on fertility preservation has surged from just a few papers in the early 2000s to over 100 papers published a year since 2020. Initially, most of the research focused on oncological preservation, calling for multidisciplinary teamwork, but recently more and more studies are appearing on elective social freezing and highlighting motivation, legal aspects, ethical aspects of fertility preservation. But studies show that we feel still uncertain discussing fertility preservation with our patients. We are reluctant and hesitant to share personal opinions and discuss expectations with the patients. Patient consultations should include risks, benefits, costs, duration of storage of the oocyte, long-term outcomes, and we should portray a transparent provision of success rates to ensure patients can make a quality-based decision when deciding if to preserve their eggs or not. Probably the first question we will encounter is, how many eggs should I freeze? This is a question that came up over the past 2 days in all of the talks almost, and it's probably the toughest question to answer, since there is no numerical number that we can give. It depends on so many factors, and especially depends on the future family planning that the patient wishes to have. So we don't know exactly how many eggs, but what we do know is that as women age, we need more oocytes in order to achieve a successful pregnancy. This is because the likelihood of a mature oocyte to reach a euploid embryo declines from 25% in her early 30s to less than 5% in her 40s. We're all familiar with Dr. Sankara's study on over 400,000 cycles, saying that the more oocytes, the more likely we are to succeed. She says that cumulative live birth rates increase to 15 oocytes. They reach a plateau between 15 and 20 oocytes, and they decline after 20 oocytes in fresh cycles. But recently, a systematic review came out, and I think this paper was also presented in the past 2 days, showing that the cumulative live birth rate increases over 20 oocytes. The more oocytes we have, the more likely we are to have a pregnancy. This was all true for fresh cycles, but what can we say about frozen oocytes, the vitrified oocytes, as we have in fertility preservation cycles? So Koba was the first one in 2013 to show that the comparable success rates of vitrified oocytes with fresh oocytes in 30 women who returned to utilize their eggs. This was in 2013. And in 2021, she published a recent data on fertility preservation of elective freezing of patients with endometriosis and oncological preservation. And highlighted in this table, we can see the outcome of 641 women with elective fertility preservations. And we can clearly see that when we freeze 15 eggs before the age of 35, we have a 70% chance of a live birth, which is really, really high. And after the age of 35, it drops to 39% with vitrified oocytes. She also shows that each additional oocyte adds to the live birth rate substantially before the age of 35 and less substantially after the age of 35. So this was the first publication regarding frozen oocytes. Since then, a few publications have appeared, and I'd like to walk through a few of the most important, I think, studies that came recently and affect the way that we provide information to our patients regarding fertility preservation. In 2016, Doyle publishes this really interesting paper, and he summarizes 117 cases of women who came back to use or utilize their eggs that they froze. This is the results of 128 warming cycles. And what he shows are comparable results of vitrified oocytes with fresh oocytes, very similar to other studies. But what's interesting in Doyle's paper, if you really read into the lines, you see that they froze mature and immature oocytes. I don't know how many of you freeze immature oocytes only to thaw them and mature them in vitro. I don't. Anyway, in the paper, 10%, it's an anecdote, but it's interesting how variable the literature is. So 10% of the oocytes were immature, matured in vitro, and what they showed was that under the age of 38, 20 oocytes will yield a 70 or 80% chance of a live birth rate under the age of 38, and after the age of 38, you'll probably need 30 oocytes. This influenced decision makers and formulated policies regarding fertility preservation. A year later, Goldman published this really interesting paper and created a counseling tool using a Poisson regression model. Their first equation estimated the chance that one mature oocyte will develop into a euploid embryo. It's multiplied by 0.95, indicating that there is a 95% survival rate of oocytes under the age of 36, and it was multiplied by 0.85, showing an 85% survival rate of oocytes after the age of 36. And the second equation predicted the chance that a euploid embryo will result in a live birth. Now, this is based on reprogenetics data of 14,500 PGTA results. And they multiplied it by 0.6 in order to say that there's a 60% chance for a live birth rate. And that's how they calculated the chance that a mature oocyte will eventually result in a live birth. Using this mathematical model, they predict that if you have 20 oocytes at the age of 34, you'll have a 90% chance to have a live birth, dropping to 37% chance if you're freezing eggs at 42. As fertility preservation gained popularity, groups worldwide started examining their own preservation cycles' likelihood for a pregnancy. In 2020, Maslow, using the mathematical models of Doyle and Goldman, tried to predict what are the chances that their population who froze eggs with them will have a live birth. And they showed that 66% of the patients had an estimated live birth of 50%, and 51% had a 70% chance to have a live birth rate with their first preservation cycle. It, of course, increased to 79% to have a 50% estimated live birth rate and a 66% to have a 70% live birth rate when you add the two cycles together. These are phenomenal results, right? Almost all of their population had a 50% chance to reach a live birth with their frozen oocytes. Han took it one step forward and said, okay, I don't care about one live birth. Let's see what are the chances for a patient who freezes 10 eggs to have 2 live births and 3 live births from their same 10 oocytes. And from Goldman and Doyle's calculations, they reached the conclusion that if you have 10 oocytes at the age of 35, you have a 70% chance to have a live birth and a 30% chance to have 2 live births and a 9% chance to have a 3 live births just with 10 eggs. Recently, there was this ART calculator. It's by Poseidon's group. It's online. It's free. You can use it. And what it does, it tries to estimate the number of mature oocytes you need to achieve a euploid embryo. Now, it takes into calculation pre-treatment and post-treatment information. So the pre-treatment says, let's just take an example here, a woman who is 37 years old using ejaculated sperm will need 11 mature oocytes to reach a euploid embryo with an 80% success probability. And then a post-treatment calculation says that the same 37-year-old woman using testicular sperm, for example, this is just an example, who already retrieved 7 mature oocytes, has a 54% chance to deliver with an 80% success probability. These are really amazing results. So what's the problem? The problem is that we might, and I'm saying this very carefully, we might be giving our patients unrealistic expectations based on unvalidated and optimistic predictive models. This is my thought. Because what happens here is that these probability calculations are based on assumptions that there's equal fertilization and blastulation rates from fresh and frozen oocytes. The second thing is that they rely mainly on Goldman's calculation based on reprogenetics data. Now, it's written in the paper. You just have to read. It's not hidden anywhere, and I didn't have to dive into the literature. But it says that it's based on reprogenetics data on 14,500 PGTA cycles. But then if you look at the brackets where it's cited from, it cites Barish Atta's study on 7,700 embryos and unpublished data, which remains unpublished till this day, which means that 7,000 embryos are unaccounted for, making the validity of the data questionable. And it assumes a 60% live birth rate for euploidy. So this is based on, for live birth from a euploid embryo, this is also based on very outdated data. Maybe the AI now, this is the new gadget, will be able to predict better the fertilization, implantation, blastulation, live birth rates of a single oocyte. But this is yet to be seen. For now, what we have is real-world data on actual success rates. And Safir and colleagues actually published in HR last year this systematic review and meta-analysis on live birth rates per transfer from planned cryopreservation cycles. So this is true elective cryopreservation. It summarized 10 studies, including 1,500 women, and a return rate of 11%. The oocyte survival rate was 78%, and fertilization rate was 72%. Actually, only 4 studies reported the patient characteristics, so it's really based on 4 studies that we know the age of the patient and other additional important information. And what we know is that the mean age at retrieval was 38, the mean number of oocytes retrieved was 12, and this was in a mean cycle of 1.4 cycles. They reported an overall live birth of 28%. Orvieto's editorial challenged the presentation of the data and said that the actual live birth rate patients should be informed of is actually 2.8% per oocyte. Because if you divide the total live births with the number of thawed oocytes, this is the number you reach. So now, walk with me through this. If we have 10 eggs in a normal responder patient, and we have a 28% chance of a live birth rate, first of all, it's similar to Kobo's data, so that shows that it's pretty consistent, and it's much lower than the predicted calculations in all of the predictive models out there. How should we consult poor responder patients if 28% is the data on normal responder patients? And does knowing if a patient is a poor responder in advance change our recommendation or affect our approach? So the reason I wanted to talk about fertility preservation in poor responders is because I encounter it quite often. Israel is recognized for its progressive health policies on fertility preservation. It was among one of the first countries to regulate egg freezing for non-medical reasons. Since 2009, elective egg freezing is allowed in Israel, and it's allowed for up to 6 cycles and up to 35 eggs, depending on the age of the patient. National data shows that there are 60,000 cycles in Israel. 50% of them are fresh cycles, meaning that there is an egg collection, and 30% of them are fertility preservation cycles, meaning that we have in Israel, just in Israel alone, 9,000 cycles which are fertility preservation. So 70% of these fertility preservation cycles, 70% are medical fertility preservation, meaning that there's an indication to preserve her fertility, either endometriosis or cancer, or what was included only in the last reform of the policy was to fund fertility preservation for women with a low ovarian reserve. Under the age of 39, women with an FSH of 10, an AMH below the 25th percentile, and an AFC below 7, you had to have 2 of the 3, and then you were funded for the preservation. And 30% are elective fertility preservation. Now, some of these elective fertility preservation, they come into your clinic, right? They want to preserve the fertility, and during the process, or following the first cycle, you realize that they are poor responders, or there is a low number of eggs. So this is the place to distinguish between poor ovarian response and poor ovarian reserve. We use these terms interchangeably, but they are very, very different. They're different in everything, in the diagnosis, in the pathogenesis, and most importantly, in their prognosis, right? Because poor ovarian reserve indicates a depleted ovarian egg pool, suggesting a permanent condition, whereas poor ovarian response may be temporary and could improve with appropriate treatment. So Poseidon classification set out to separate these two groups of patients by ovarian reserve and by response. We have the unexpected group, groups 1 and 2. These are patients with a normal ovarian reserve, but after stimulation, you realize that they are hypo or poor responders. And there is the expected group, right? Groups 3 and 4, where we know in advance that these are patients who have a poor ovarian reserve. Ovarian aging and depleted ovarian reserve cause molecular changes in the ovary. It affects FSH glycosylation. We know that women with advanced age have a lower hypoglycosylated FSH. The FSH 18 and 24 are, and 21 are lower, and they are the more bioactive, and the FSH 24 is the less bioactive. And we know that it affects oocyte development, maturation, fertilization, implantation, and maybe, I say this again carefully, maybe euploidy of the embryo. Why do I say maybe? Because we discussed this yesterday, whether the number of oocytes that we retrieve from a patient also affects embryo quality. This systematic review and meta-analysis of 28 studies, including 290,000 cycles, confirms a positive correlation between the number of oocytes retrieved and the chance that we will have a high-quality embryo. And this suggests that patients with a poor response have a lower chance to achieve a high-grade euploid embryo. So this indicates that even with multiple cycles, we may never reach the goal of acquiring a good quality embryo and achieving a live birth. So again, back to my calculations, maybe 10 oocytes, right, retrieved in a single cycle are not the same as 10 oocytes accumulated in 2 or 3 cycles. The answer is, I just don't know. It's what I'm thinking and sharing with you, but there's no scientific data on preservation cycle success rates in poor responders regarding the number of oocytes or the number of cycles that we need to perform. What I think we could say after everything we heard yesterday and today is that the prospects are very different for 5 oocytes from poor ovarian reserve patients following a maximal stimulation and 5 oocytes from a normal responder with a hypostimulation or minimal stimulation. So 10 is not always 5 plus 5, and 5 is not always 5, if you get what I mean. So what I said is, okay, I don't have the answer. Let's look at the cumulative live birth rates in poor responder. There are numerous studies on fresh cycles in poor responders and the cumulative data. We can try extrapolating from these studies and understand how many cycles we need and how many eggs we need in a poor responder patient. But this gets even more complicated because the term cumulative live birth rate varies significantly from study to study. There are 3 different ways to define cumulative live birth. It sounds simple, but it's not. There is the conditional, conservative, and optimistic cumulative live birth. So conditional is probably the most reliable because it includes the fresh cycle and all the subsequent frozen cycles after. So these varying definitions make it really hard for us to give a proper consultation to our patients regarding the number of eggs and the number of cycles we need. So I'm coming to the end of the talk, and I don't want to leave you with a pessimistic note. I'll just say that managing poor responders in our clinic that are trying to get pregnant, I'm not talking about preservation cycles, is challenging, right? There are high dropout rates, there are low expectations, high emotional stress. These are all very common when treating them when trying to get pregnant. So you can imagine that when you do it with fertility preservation cycles, it's even more challenging because first of all, we're delaying her pregnancy. And second of all, we don't really know what to say when we get these results regarding preservation. But what can we offer to improve the chance? And this is what I think. I think we should first of all increase awareness. I'm on this calling, going from gynecologist to gynecologist, sitting at the clinics, and calling them to increase awareness to test ovarian reserve. We should maybe consider periodically stopping oral contraceptives, testing ovarian reserve, and see what the chances are. Because what happens is that when a patient takes oral contraceptives from the age of 18 to the age of 35 and she never stops them, we're masking the true ovarian reserve. So maybe we should consider from time to time stopping the contraceptives, risking pregnancies, and testing the ovarian reserve. The second thing is, I'm joking, not risking pregnancies, okay? But like inform them like we should. But this is something to be thought about. Second of all is to maybe promote early fertility preservation. I know Professor Ben Raphael thinks that when we preserve our eggs at an early age, it's not cost effective, and it's true. But studies show that women with a low ovarian reserve, poor responder patients, return to use their eggs much more often and much sooner than other subpopulations. So it might be cost effective in this population. And third, maybe the most important thing, is maybe stop and plan for the second cycle as you would a fresh cycle when a patient is trying to get pregnant. I mean, put into the planning the same precision and intent that you would as a fresh conception cycle. So maybe consider performing back-to-back cycles or duostim to decrease the dropout rates, and maybe bring the patient in for AFC and FSH testing at the beginning of the cycle. So in order to decide which cycle to start, because we know there's a cycle-to-cycle variability. And change protocol from time to time. Change gonadotropins. We have numerous gonadotropins to choose from. We have Recovel, which is a different FSH glycosylation pattern. We can add LH, we can add HCG. We have all these options that we could choose from. We could increase the FSH starting dose. We could change the triggering. You should put thought into the second cycle, even if it's a preservation cycle, in order to improve the outcome. We should consider add-ons, even if these are preservation cycles. And most of all, maybe, carefully, we should consider all the options, even trying to conceive. Tell the patient, listen, we'll do the preservation, but straight after, I recommend you trying to get pregnant. Even take donor sperm, or discuss it with her. Or maybe forsake the preservation and go straight to trying to get pregnant. In summary, I think that oocyte vitrification, like other innovation, follows the Gartner hype cycle, which starts with high expectations from success stories, followed by disillusionment due to failures, with a slope of enlightenment to plateau productivity. I believe we're now in the enlightenment phase, where proper patient counseling is vital for setting realistic expectations, especially in poor responder patients. Thank you.